I'm excited to introduce our next speaker, Andrew Sperling, who is the Director of Federal Legislative Advocacy at NAMI National and has been so since September of 1996. He received his bachelor's from Tulane University, his master's from George Washington University, his law degree in 1992. But most importantly, he's a native Alabamian. He is from Birmingham. So, hey, even though it's virtual, welcome back to Alabama, Andrew. He directs NAMI's legislative advocacy program in Congress and before federal agencies. Since 1994, he's also served as a co-chair of the Consortium for Citizens with Disabilities Housing Task Force, which is a coalition of national disability advocacy and provider organizations dedicated to promoting policies and funding to increase access to affordable housing opportunities for non-elderly adults with severe disabilities. So welcome, Andrew. Thank you for coming and joining our 35th annual NAMI Alabama meeting. I'll hand it over to you.
Thank you, Connie. So one of the good things that has come out of this pandemic is that I don't have to do my job in Washington, D.C. in the NAMI National Office in Arlington, Virginia. So for the past 14 months, I have been working out of my apartment in Birmingham. So this is not coming home. I am home. It's been much easier to ride out the pandemic here in Birmingham. And when all this comes to an end, when and if it ever does, one of the bad things is I'm going to have to go back to Washington and spend more time in Washington and less time here at my apartment in Birmingham. But it's great living at home again through all of this, despite all the challenges. And of course, I don't know which button to hit to advance the slide.
You should just be able to click it.
Click it. Click what? Click. Ah, here we go. Okay. So before we go any further, I do want to say a word about our dear Rogine. It was 25 years ago this week that I was still working at the National Council for Behavioral Healthcare, or Leland's called the National Council of Community Mental Health Centers. And I had been offered a job at NAMI to go to NAMI, and I accepted the job. And I was scheduled to be on the agenda at the Alabama Council meeting in August of 1996. And I called our old friend, Jim Dill. Many of you remember Jim, a longtime executive director of the Alabama Council. And I said, you know, Jim, I got some bad news. I'm leaving the National Council, but the good news is I'm going to NAMI. And I know I'm on the agenda to speak about what's going on in Congress at your conference. And I'm more than willing to back out since I've only got this is my last week on the job at the National Council. And Jim said, no, come down to Birmingham. We would love to have you. And this was at the Birmingham Jefferson Civic Center. I walked in and Jim was there with a big smile on his face to greet me. And he had 3 people with him that he wanted me to meet immediately. And it was Rogine Parrish, Ann Dimbo, and a number of you that are NAMI veterans will remember the late Fred Freeze from Ohio, who served on the NAMI board for many, many years. And they had actually pressured Jim to have Fred come and give a talk at the Alabama Council meeting. And that's when I first met Rogine. And it really, her spirit, her advocacy, her drive for the last 25 years has really been a beacon for me in being an advocate for people with mental illness in Congress and before federal agencies. And she's just a very special person. She'll be sadly missed. I apologize for the quality on this slide. I joined many of you at the celebration of her life and her memorial back in June in Pelham. And I wanted to at least acknowledge her the way in that the beautiful video and tribute earlier. Rogine was just terrific, and she will be sorely missed by all of us, but her work will continue. We need to continue the work of NAMI Alabama in her spirit, and I look forward to continuing to do that with all of you. So taking stock of where things are, you know, I look back my 25 years at NAMI, is the glass half empty or is the glass half full? We have a lot we can be proud of, but we still have a long way to go. And I'm going to do the bad news first. So we still have a long way to go to get where our colleagues in diabetes, cancer, and heart disease are. We still have imprecise diagnoses. We are still using a diagnostic statistical manual that the APA publishes. It just looks at clusters of symptoms, right? We would never diagnose heart disease based on what's the severity of your chest pain from 1 to 10, right? They have much more precise diagnostics in cardiology and other areas. We need to get to better diagnostics. We know that mortality from suicide now exceeds that of breast cancer and prostate cancer. Why is that? Because we stay steady at about 48,000 suicides a year, whereas all the advance in early diagnostics and treatment and prevention and all other areas of cancer have lowered that mortality rate. We need a lot of work to do on suicide prevention. We're starting to learn what works. We just got to adopt it. Early mortality, that your commissioner talked about this, the life expectancy of an adult with serious mental illness hovers just that below of an adult in Bangladesh. And I use that number because people differ on what the baseline is, but for the rest of the population, we know they're not dying of their underlying psychiatric disorders. They're dying of 3 and 4 multiple chronic medical conditions, all of which are poorly managed. Diabetes, heart disease. It is heartbreaking for me when I go out on the road, and again, we haven't done it for the last 18 months, but when I go to a NAMI state conference, I talk about, well, where is this leader of NAMI, a NAMI mommy who's, maybe in her 60s or 70s, has been active, taught family to family. Turns out the month before, her son, 40-year-old son, died of a heart attack. That's just heartbreaking. And that's why she left NAMI. So we have a lot of work to do. Innovation in drug development. Look at where we were 25 years ago. HIV, a diagnosis of HIV, you were staring down the barrel of a gun of 9 months mortality. Today, 25 years later, you have a normal life expectancy. You're more likely to die of heart disease than you are of a compromised immune system. They did that in 25 years. The APA is now in the process of finalizing their treatment guidelines for schizophrenia. They are going to recommend as a first-line treatment, clozapine, a drug that's been around for 40 years. Right? We have to do better. If I was doing this presentation live, I would ask for a show of hands. How many of you in the audience are content today with the therapies we have to treat schizophrenia? And I can promise you, not a single hand would go up. We have to do better. And we know that large American companies have backed out of psychiatric research. There's a cadre of smaller biotech companies that are now, some of them have drugs that are in phase 2 and phase 3 clinical trials. We are hopefully seeing the beginning of a new wave of new therapies out there, particularly some of them may be marginally better, but they won't have weight gain associated with it. That's a huge step forward for many people, right? To have an effective antipsychotic that doesn't have weight gain associated with it. Too many people with mental illness in the criminal justice system. Your commissioner talked about that in detail. Brian touched on it as well. This is a major effort in the NAMI National Board strategic plan of diverting people out of the criminal justice system. We're still a third of the SSI roles and a quarter of the SSDI roles. This consigns people to a life of poverty, particularly SSI, where the rules bar families from helping with rent and food, and it consigns you to poverty for the rest of your adult life. We can make some changes in those programs. Unstable housing. Housing is a big issue for many of you, I know. Helping your loved one get and keep stable housing. Not enough inpatient acute beds. Brian talked about that, about the dilemma we find because of the lack of acute care beds and what you're doing here in Alabama. And your commissioner talked about those crisis centers in Mobile, Huntsville, and Montgomery that are being stood up. We got to do a lot more to improve crisis care. All right, so enough bad news. How about some good news? We know recovery is real. We know it's achievable. We know what works. We have lots of interventions out there with enormous, impressive evidence behind them of their efficacy. Early intervention, the RAISE study the NIMH undertook, the coordinated specialty care that got better outcomes for young adults experiencing first episode of psychosis, assertive community treatment, supportive housing. I could go on and on about all of these. You heard about AOT from Brian. We know it works. There's a substantial body of evidence demonstrating we're just failing to do it. Peer support, better medications, integrating primary care and specialty care, addressing comorbid chronic medical conditions that drive that early mortality. And then finally, I would note, in my 25 years, I've never seen stronger bipartisan support for mental health in the Congress of the United States and with the current administration and the previous administration as well. Mental health is now something talked about much more in public by public officials and has strong bipartisan support. And I'm going to talk a little bit more how that's, I can demonstrate that in terms of the investments that are being made. So this is NAMI's federal legislative agenda. There's a lot of things here. I won't go through all of these in detail, but we need more research on talk about the budget for the NIMH and what Dr. Gordon is doing to try and advance things at the NIMH. Health coverage, early intervention. You heard from your commissioner about 988 and what we're going to have to do. I'm talking a little bit more about money. the resources they're going to take to stand up an evidence-based crisis response system, and the work that needs to be done here in Alabama on that, promoting peer and family supports, safe, affordable housing, integration of care. A lot we need to do, to really bring about a better mental health system for our loved ones. So let me talk about COVID just for a minute. We've gone through this process now for the last 18 months. The early months were very, very disturbing. And what we knew was happening, and if you were at the NAMI virtual convention a few weeks ago, you saw some evidence that Dr. Josh Gordon, the director of the NIMH, presented on higher rates of mortality among people with serious mental illness. This was largely a product of people that had a serious mental illness before the pandemic struck. We know that many of them were living in congregate settings, right, where it was virtually impossible to comply with CDC guidelines on social distancing and other things, where you have 8 or 10 men in a group home that are sharing a common bathroom, common eating area. Your ability to socially distance, it was virtually non-existent. So we know that there were instances in the early days of the pandemic of the virus going through congregate facilities. And we know that these individuals, because we talked about earlier, in terms of high rates of respiratory disorders, of diabetes, obesity, other things, that their risk of mortality once they contracted the virus was dramatically higher than the general population. So I apologize that I don't have the graphs and the fancy graphs that Dr. Gordon presented a few weeks ago at the NAMI National Convention, but I'm happy to get some of that material. It was really disturbing, some of the data that we're now seeing emerging of higher risk of contracting the virus, and if you contracted the virus, dramatically higher rates of mortality because of your circumstances. And again, these are individuals that were diagnosed with a serious mental illness before the pandemic struck. What we see coming next over the next few years is going to be what Dr. Tom Insel, the former director of the NIMH, he called this normal reaction to abnormal circumstances. And this is work that he did with the military over the last 20 years throughout the struggles and the conflicts in Iraq and Afghanistan. So young military officers, enlisted personnel that witnessed traumatic things, roadside bombs, things like that. They're experiencing anxiety, depression, higher rates of misusing alcohol and drugs. That's what he defined as normal reaction to abnormal circumstances. What we've been going through over the last 18 months is not normal. And we expect people to experience these symptoms. What we want to be careful we want to intervene early, but we want to also make sure that we allow for the resilience of individuals and that they're going to get through this without ever having been diagnosed. So there's a lot of work we're going to be doing with primary care system, with the mental health system, to identify people that are experiencing what are normal reactions to abnormal circumstances of what we're going through have been going through over the last 18 months. So Congress reacted to this, to mental health and the need to have a robust response so that the mental health system is there to address all of the challenges coming through this pandemic. Now, these are all emergency one-time funds. This is a bill that passed in December of 2020 and was actually signed into law by former President Trump. And you see these big numbers here. So I'll highlight that first one for you. $1.65 billion, a one-time allocation to the mental health block grant program. The budget for that program is normally about $740 million. So a one-time emergency allocation of funds that's double the entire amount of the mental health block grant. And you can see, you heard about the CCBHCs from Commissioner Boswell. That's $600 million. Now, not all that now is going to CCBHCs that hopefully some of your community mental health centers here in Alabama are going to be eligible for. And you can see some of those other smaller numbers. But this is these are big numbers for mental health, dollars that are still being pushed out the door to Alabama. Then we had, just a few months later, in March of 2021, the American Rescue Plan, again, which passed with only Democratic votes, but again, big numbers, $1.5 billion for the mental health block grant, $140 million for frontline mental health programs, $100 million for workforce training. We know that you here in Alabama, as all parts of the country, are experiencing a real crisis in terms of the adequacy of the mental health workforce. You can see some of those other numbers, $80 million for pediatric, $128 billion for schools. So big dollars being being allocated. I want to talk a minute so about that last bullet there. So more money was put on the table for states that have not expanded Medicaid, and Alabama is one of those states. And the struggle over expanding eligibility for Medicaid, which is now optional. So some of you may recall back over a decade ago when the Affordable Care Act was passed, in 2012, a challenge went up to the Supreme Court, and the Supreme Court struck down mandatory expansion of Medicaid eligibility that had been part of the ACA and essentially flipped it over to be an option. And so here we are a decade later, and Alabama has not expanded Medicaid eligibility. And there's still efforts to make that happen. But these are big numbers for the state of Alabama. And I just want to make clear, because NAMI National supports Medicaid expansion. We've worked with our NAMI state organizations in states in recent months, like Oklahoma, like Missouri, to get that expansion. But these are big numbers. If Alabama were to expand Medicaid, the number of uninsured in the state would drop by 43%. That's about 314,000 Alabamians that would get coverage, and that includes 75,000 people that have no coverage at all whatsoever. And over 10 years, the 10-year window, if Alabama were to expand Medicaid, it's $4.9 billion in federal funds that would flow into the state of Alabama. And I'm not trying to be partisan here at all, but the reality is when you talk to your rural hospitals across the state of Alabama that have closed, many of them will fess up and admit, had Alabama expanded Medicaid, many of those hospitals would never have had to have closed. So it really is something that NAMI National feels strongly about. We know that there's partisan differences over this, but it really would be a huge step forward when and if Alabama decided to expand eligibility for Medicaid. Okay, so the next big bill that's coming is something called a budget reconciliation bill. I will not bore you with what this is because it's very complex rules, but what it means is that this would be a big budget bill that could be passed with only Democratic votes. Okay, but there are narrow margins in the House and the Senate. It's only about an 8-vote margin in the House, and the Senate is 50-50 with Vice President Harris breaking the tie. So there's no room for error for the Democrats in advancing this bill. They passed a budget resolution about a week and a half ago that opens up the process to do this budget reconciliation bill, which doesn't require a 60-vote majority, and which the previous infrastructure plan that the Senate passed a couple of weeks ago did. There's not a lot about mental health in there, but 2 items I would note. There's $400 billion in funds for Medicaid home and community-based services. This would include mental health services. There are a lot of technical rules that apply to this, and it still isn't clear how much of this is going to get in the bill and what rules are going to apply, but it would provide a new option for Alabama to finance home and community-based services as part of the Medicaid program. This is for elderly and people with disabilities, but would also include people with mental illness. And then big dollars for HUD, $332 billion. This is essentially more than triple the entire annual HUD budget that will be allocated for new housing opportunities. This would include a program called Section 811, which builds housing for non-elderly people with disabilities, including people with mental illness. But this thing is iffy in terms of, so any defections on the Democratic side can sink the entire process. So we're going to be watching this closely in September and probably into October as they try and advance this bill. Very partisan. You'll hear a lot of your Republicans in the Alabama delegation. I just saw there was another, Senator Tuberville made another statement yesterday criticizing this bill. This is there are sharp partisan differences over this bill, and you're going to see this play out in the coming weeks. All right, let me talk a little bit about some of the, I mentioned, in the investments that are being made in mental health services and mental health research. Let me first talk about research. And these are, again, this is a bill that advanced in the House, passed the House the last week of July. The Senate has not taken it up yet, but it's something called the FY22 or 2022 Labor, Health, and Human Services Appropriations Bill. So this is the annual budgets for the Labor Department, the Health and Human Services Department, the Education Department. It is a big bill, but they're big increases for mental health. And I want to highlight some of these. So that day when I met Rogine for the first time in 1996, and I started at NAMI, the NIMH budget, the National Institute of Mental Health budget, what the federal government was directing to research on schizophrenia, bipolar disorder, major depression, PTSD, all of them, was about $310 million, okay? And today, it's $2.213 billion, okay? So that's nearly like a 5 or 6-fold increase if you do the math. Just the increase coming into next year, if we sustain this, is $119 million. And it's up nearly $500 million since 2014. So what we had in that period, right after I started at NAMI, was an attempt to double the budget for the entire National Institutes of Health. We did that. And then for a number of years, the budgets were flat. And then starting in 2014, Congress began increasing the budget for the National Institutes of Health again. Lots of people deserve credit for this. I'm not one of them, but one who certainly deserves credit for this and who's been a champion for the NIH is our great Senator Richard Shelby. He has been a champion for both mental health research, but all health research. And you can see that with the Shelby building right there on University Avenue and 19th Street. There's a Shelby building in Tuscaloosa. I think the reason these universities continue to name buildings after him is because he's done so much to bring research dollars to UAB and other research institutes across the state of Alabama. And he's been a champion for NIH, for NIH and for NIMH, and none of this would have happened without his leadership. We've also made big investments. Congress has also made big investments in something called the BRAIN Initiative, which stands for Brain Research through Advancing Innovative Neurotechnologies. This is really not about research on schizophrenia or Alzheimer's or Parkinson's. It's really about mapping the brain, technologies to better undertake brain research, different technologies, and it's really been important in advancing research. The brain is the most difficult and challenging organ of the body on which to conduct biomedical research, and we need to. And the Brain Initiative has been very, very, very important in advancing the technologies to bring that research forward. We'll talk a little bit about services at an agency called SAMHSA, which stands for the Substance Abuse and Mental Health Services Administration. And Commissioner Boswell talked a little bit about SAMHSA dollars that are flowing into the state of Alabama. So this bill that passed the House a few weeks ago, the last week of July, and will be taken up by the Senate in September and October. It includes another big increase for the mental health block grant to $1.6 billion. Again, it's an $825 million increase over the current level. But importantly, it includes two set-asides, one of 10% for crisis response, right? So these are dollars that the state of Alabama can use to stand up crisis response, implement 988, develop mobile crisis teams, other things to really advance crisis response. And then another 10% set aside that existed previously for early intervention in psychosis, to stand up what's called coordinated specialty care for first episode psychosis. We know that the earlier we intervene, the better the outcomes. And so this will help Alabama advance and replicate coordinated specialty care for first episode psychosis. There's another $100 million program for mental health crisis response, a partnership pilot program that Alabama would be able to compete for. And then because of the, and again, the 988 is supposed to go live 11 months from now, in June the end of June of 2022. So we've got a lot of work to do between now and then. And there's a substantial increase of $113 million for the Suicide Lifeline. These are the call centers that are right now very under-resourced relative to the burden that we think is coming, right? So we know that one of the things that we hope we're going to have in place is a screening tool, a mechanism that when someone calls 911 and we realize, and the dispatcher realized fairly quickly that this is not a medical emergency, but rather a psychiatric emergency, a mental health crisis situation, instead of having the call routed so that law enforcement is the initial response, we're going to be able to have it go to 988 and have the initial response be either a hybrid of law enforcement and mental health or purely a mental health response, right? We want to get to a norm where when someone is in crisis, it is mental health that shows up first, not law enforcement, right? We've done a lot here in Alabama with CIT to train officers, but in a perfect world, the response is not going to be a law enforcement response. It's going to be a mental health response. So we need big resources to make this happen, and Congress is investing in important resources to stand up these call centers and have the three-pronged approach that your commissioner talked about: someone to take the call, someone to screen the call, someone to go out, and a place to go. We've got to have all three to have a good, positive evidence-based crisis response system. We talk a little bit about housing. Housing is critically important. I spent a lot of time working on it. There's a draft bill that also advanced in the House, passed the House the last week of July, that funds HUD programs. There are big increases there for supportive housing. I mentioned that the Section 811 program at HUD, Senator Shelby has been very, very helpful through his perch on the Appropriations Committee to get more resources for this program. And there's $160 million to develop as many as 1,800 new units. So it's not just, some of this money has to go to renew the existing rent subsidies for the people that currently live in 811 properties, but there's significant money available to expand and build new units, which is really, really important. And then a $420 million increase for the McKinney-Vento Homeless Assistance Act, bringing that program up to $3.4 billion. And this program is really focused not just on homelessness overall, but particularly on chronic homelessness, which is really the phenomenon experienced by people with mental illness, particularly people with untreated serious mental illness, who, when they get into homelessness, they tend to stay longer. And we need more nuanced and effective interventions to help them escape long-term chronic homelessness. And that includes an evidence-based model called permanent supportive housing. The McKinney-Vento program does a very effective job of developing permanent supportive housing. So we're not transitional, we're not moving someone just from a shelter, we're actually getting them in permanent housing that they can keep, so that they stay out of homelessness and they're better able to adhere to treatment, and it drives better outcomes, both in terms of managing their underlying psychiatric condition, but also likely maybe a drug or alcohol problem, or 3 or 4 chronic comorbid chronic medical conditions that they experience that drive that early mortality and drive the bad outcomes. The VA, very, very important. You have really one of the best facilities here, both the VA hospital on the south side and then the new VA clinic closer to St. Vincent's. A lot of very important work has been done in the VA with mental health. And these are big, sort of staggering numbers. This is 13.2, so there's a draft House bill that hasn't passed the House yet, but will likely pass in September, that allocates $13.2 billion in mental health funding at the VA. Before the conflicts in Iraq and Afghanistan, the VA didn't allocate even a separate amount of money for the VA for mental health. When they started tracking that, it was usually around about $1 billion, barely a decade ago. Now it's $13.2 billion. The increase alone from FY21 to FY22, if this bill passes, is almost $3 billion. So that's about half of the SAMHSA budget. That's just the increase alone, right? This $13.2 billion is nearly double the entire budget for the Substance Abuse and Mental Health Services Administration. So what the federal government invests separately in funding for mental health and substance abuse, what the VA is spending is nearly double that amount, okay? And there's a 59% increase for the Veterans Crisis Line in this bill. So big, big dollars for the VA. We all know why this is justified, given the sacrifice, particularly the younger generation of veterans for our country in conflicts in Iraq and Afghanistan. This is a commitment we have to keep. It creates challenges. And one challenge I'll mention is, and I'm sure Commissioner Boswell could line up your community mental health center directors and your clinic directors and across Alabama and can talk about the workforce shortage. And one of the things that drives that shortage is that if you're a licensed clinical social worker, you're a mental health counselor, you're a psychiatrist, you're a clinical psychologist, and you're working at a community mental health center in rural Alabama, you can likely double your salary if you're willing to go work at the VA, because they have plenty of money. Now, no one's begrudging that, right? There's nothing inherently wrong with that. We want our veterans to get the best possible care, but it is a challenge to keep and retain people when you've got an employer down the street that can pay a lot more money. And we know the VA is doing that, and we know it's justified. No one's complaining. It's just, it has some consequences in terms of maintaining a strong behavioral health workforce in Alabama when the VA can offer a lot more money. The VA does very important work in research in PTSD and other mental health disorders. And there's an $87 million increase coming in the budget for VA research, bringing that up to $902 million that the VA spends in research. It's an important research institution in our country. So I'm going to sort of end here, and I hope I haven't gone too quickly. I leave time for questions that I can respond to in the chat. I want to talk a little bit about working with the Alabama congressional delegation, because I've done a lot of that over the years. This is not meant to be an exhaustive list by any means, but I'm sort of highlight the positions that our leaders in the Alabama delegation hold in Congress, because a lot of important work is done in committees, and the committees that members serve on are very, very important and drive their ability to really influence legislation and deliver for the state of Alabama. And no one has done that over the years. Really, in my lifetime, I was actually in high school here in Birmingham when Senator Shelby first got elected to the House in 1978. Shows you how old I am and how long he's been serving. And he has been in the Senate since 1987 and served for many, many years on the Appropriations Committee. He has been chairman of the Appropriations Committee. He's been chairman of the Banking Committee. And now he's the ranking member of the senior Republican on the Appropriations Committee. And that is still a position of enormous influence. And he continues to deliver for the state of Alabama. And we now have essentially one more year, a year and a half of him serving as our senior senator and dean of the delegation. And we know that he's going to continue to deliver for Alabama, but unfortunately it's only for another year and a half. But he's done a lot for all of NAMI's priorities, but up to including not just NIMH and SAMHSA, but also HUD. And he will be sorely missed when he retires from the Senate. Senator Tuberville, our newest senator, he is a member of the Health, Education, Labor, and Pensions Committee. That's what that acronym stands for. They have jurisdiction over SAMHSA, over the NIH and the NIMH, but they also have jurisdiction over something called the Public Health Service Act, which is where all the standards for insurance lie. So the federal standards for insurance for both something called ERISA, which I won't bore you with what that is, and the Public Health Service Act. Those are the laws that the Parity Act amended. So parity, compliance, and enforcement of parity is something under the jurisdiction of the Health Committee that Senator Tuberville serves on. And we continue to do a lot of work with that committee in making sure that the full goal, the full aspirations we had for parity in terms of ending discrimination are achieved. And we're not there yet. So it's something that we're going to continue to push on. And we certainly want to work with Senator Tuberville to make that happen. Congresswoman Terry Sewell is on what is really, many recognize as the most influential committee in the House of Representatives, the Ways and Means Committee that has jurisdiction over Medicare and Social Security. So the Medicare Part D program that many of you have a loved one who's a dual eligible and they get their drug benefits under Part D. We've done a lot with with Congresswoman Sewell's office to make sure the Part D program works. Social Security, she serves on the committee that has jurisdiction over SSI and SSDI, which are really, entitlement income security programs that many people with mental illness depend on. We're hopeful that big $3.5 trillion bill will include something to amend and modernize some of the rules around SSI in particular. There's something called in-kind maintenance support. If you have a loved one on SSI, you know what that is. It severely restricts your ability to provide support for rent and food for your loved one. We're trying to modernize those rules, and I've actually been working with Congresswoman Sewell's office to make sure that happens in this big bill that they're going to be advancing in September. Congressman Gary Palmer serves on the Energy and Commerce Committee, and you would think, well, what do we have to do with energy and commerce? Well, some of the names of these committees are somewhat misleading in terms of what they're doing and the work they do. The Energy and Commerce Committee actually has jurisdiction over the Medicaid program, which again, is very, very important for financing mental health services, over SAMHSA, over NIMH, and over mental health parity. So a lot of important work that NAMI does with the Energy and Commerce Committee on various priorities. We do I try and do as much work as I can. We need you as engaged as possible. Those are you or Congressman Palmer's constituents, engage with him on these. And then finally, Congressman Robert Adderholt, who represents the 4th District, which stretches east to west and includes Haleyville, Coleman, Gadsden. He's a senior member of the Appropriations Committee. Again, as with Senator Shelby, does a lot of work on these priorities. He's actually the ranking member on the subcommittee that oversees the Department of Justice's budget. And why would that be important to NAMI? Well, we have a number of small programs at the Justice Department that provide grants for mental health courts, for crisis intervention training for police officers, for other programs that divert people out of the mental health system, out of the criminal justice system into the mental health system. So we've been working closely with his staff to try and get some of these grant programs that have been authorized but not funded so that your law enforcement agencies in Alabama and your court systems in Alabama can be eligible for funding to have a diversion court where you can engage in pre-booking diversion. So someone with mental illness who's been arrested, before they even get booked, you can divert them into a treatment, into mental health treatment, and have the criminal charges either done away with or held at bay so long as they're participating in treatment. So Congressman Adderholt's been very, very helpful in advancing and getting funding for some of those programs where we're very lucky, fortunate to have his support. Now, just a final, I'll end with a couple of commercials here. That's and again, I will make these slides available to everyone. But that website, that link there is where you can sign up to get NAMI, get advocacy alerts from the NAMI national office. And then finally, I'll do a commercial for our convention. Hopefully some of you participated in our virtual convention of the last week of July and was there to see some of the presentations, particularly from Dr. Gordon at the NIMH and others, from our CEO, Dan Gillison. But we're going to try and hopefully be in a very different position in June of 2022 and have a live in-person convention that will be close by. I think other than the convention that was held in 1996 in Nashville, this is the closest that NAMI National has ever come to Alabama in terms of holding the convention. So it's just a short drive away in Atlanta. And we hope to see many, many of you in person at the NAMI, the 2022 NAMI National Convention at the Atlanta Marriott Marquis, June 15th through 18th. So hopefully, Connie, we're getting some, I haven't been looking at the chat, but maybe if I reduce, go out of full screen, I can.
Well, Andrew, I have one question that I can, someone asked about the need for better commitment laws, which was addressed by Brian in his presentation. Yeah. But they're asking, shouldn't that, is it and shouldn't it be a legislative priority for NAMI National to make sure?
It is. So the challenge is we don't have, the only thing, so state commitment laws are governed at the state level. We've never had a situation where the federal government stepped in to impose a standard for commitment. That's always been the jurisdiction of state law. But NAMI does support assisted outpatient treatment. And we actually, I should have mentioned it, there's a small program that Brian and I work on together that funds, it's about, I think this year, about $20 or $22 million for assisted outpatient treatment. Now, it's funding, it funds grants at the state level and the local level for states that have an assisted outpatient treatment law, but are not using it, right? So it's money that can be used to train judges and how to write an AOT order. It's money that can be used for a community mental health center to stand up an AOT program. So the federal government has a little bit of room here through a grant program that states and localities are available for. But NAMI supports assisted outpatient treatment. But what we do as a national office is work with our state organizations to work on state legislation to amend your standard. So I would be happy to connect anyone with NAMI Alabama with the state team, Stephanie Pasternak and Hannah Wesolowski on the NAMI national staff that can work with you and assist your efforts in Montgomery at the legislature to bring about change in your commitment law in Alabama. But the federal government, this is not something they get involved in. This is really the jurisdiction of states to develop their own standards.
Right. And thank you for that, because Stephanie Pasternak is at National.
Yeah, and I can pass that contact information on.
Okay, that'd be great, because we have been working with Brian Stetton in the Treatment Advocacy Center to, formulate a draft bill to present in the next legislative session. So right now they're looking for a sponsor for that bill and hope to get that done. I want to ask a question about I can't remember the first name, but it was Adderholt.
Congressman Robert Adderholt, who's a longtime member of Congress from Alabama. He's actually first got elected in 1996.
Okay, and so what the committee that he's with, and they have power over some grant money for, but my ears
yes
on the mental health court. I'm sorry, that was just, you hear what you want to hear.
Yeah.
So can you give me an idea what amount of grants are available for?
I think that program got funded in the bill at $30 million, but I can get you the specifics on that. And that there's more than one of these. There's something called the Mentally Ill Offender Treatment and Crime Reduction Act that's been around for a while. That has a number of discretionary grants that are about $20 to $25 million overall. Okay, so it's very competitive. It's not a lot of money. But there's another bill that got passed last year. It was championed by Senator John Cornyn from Texas that sets up another new grant program that the Justice Department can administer for diversion programs and diversion courts.
Right. And so Alabama has 3 new crisis centers, expecting another one. And that's been just a huge win for us, you know.
Yeah, and these justice grants tend to involve court systems, right? So it because it's being funded by the Justice Department, they're not necessarily going to fund mental health services, but what they're going to fund is establishing the court, right? So that your probate judges can be working with your law enforcement to try and just not rearrest people over and over and over again, get them diverted into treatment.
Yeah, that's definitely.
You know, Connie, it's kind of strange when I'm talking. I sort of lose track of how long did I actually? Because how long? Yeah, I consumed 40 minutes. So.
You did good. Yeah. You're a fast talker.
I did one of these presentations in Nebraska a number of years ago, and then I realized I was supposed to talk for 45 minutes. I finished after 15 minutes. So. Yeah, that's great information, and thank you so much for coming and sharing with us today. We appreciate your time. And I didn't know you were back, and I didn't know you were in Birmingham. I just figured you were still in Washington, D.C. So no, I came down a couple of months after the pandemic began for a funeral, and then I realized, wow, it's so much better down here. And if I don't have to do my job in Washington, D.C., I'd vastly prefer to be here at home in Birmingham.
I'm sure of that. Yeah. Well, thank you so much for being with us. We appreciate you sharing your information with us. And if you'll send us that contact information for Stephanie.
I certainly will, Connie.
All right. Thank you so much. And
I'll obviously forward the slides as well.
Right. Yes, please. Because we've had several people ask to have your slides. Just FYI, Susan Beatty Pierce is letting us know Tina McGinnis from NAMI Birmingham Advocacy Committee will be on ABC 3340 at noon regarding veteran PTSD in the fall of Afghanistan. Her husband, retired Army colonel, served 5 years to the Middle East. He was a great advocate for all of the clinical and federal issues that Andrew is presenting on. So we've been communicating with Senator Shelby for months, many notes, great info. Lots of thanks for everything you're doing up there with the advocacy, the legislative part of it. And we appreciate you very much, Andrew.